The vermiform appendix is a dynamic, vascularly vulnerable organ. Its frequent pathologies demand a precise understanding of its highly variable anatomy and surrounding structures. Regardless of where the tip of the appendix points, surgical navigation relies on one absolute bedrock landmark, the confluence of the three cecal taenia coli. These longitudinal muscle bands trace down the large intestine and merge exactly at the appendiceal base. From this base, the organ relies on the appendicular artery. This is a strict end artery. It lacks any collateral circulation. If this single vessel is compromised, the tissue it supplies has no alternative blood source. Beyond the base, the position of the organ varies wildly. In 74% of people, the appendix is retrocecal, folding completely out of sight behind the large intestine. In another 21%, it extends downwards into the true pelvic cavity. Mapping these structural variations is the primary challenge of the diagnosis. Because the organ moves between the retrocecal space and the pelvis, the clinical presentation must be deduced by matching specific physical coordinates to physiological failure mechanisms. The central trigger for acute appendicitis is luminal obstruction. Most commonly, this blockage is caused by a calcified piece of stool known as a phacolith, or by the swelling of local lymphoid tissue. Once the lumen is blocked, the appendiceal mucosa continues to secrete mucus. With no exit, this fluid accumulates, rapidly driving up the intraluminal pressure. This rising pressure quickly exceeds the pressure of the capillary beds. Venous outflow is choked off, leading to venous stasis, tissue ischemia, and the rapid invasion of stagnant bacteria into the appendiceal wall. Because the appendicular artery is an end artery, the mounting swelling eventually compromises arterial inflow as well. The resulting thrombosis leaves the organ entirely without blood, inevitably leading to necrosis and gangrenous appendicitis. Acute appendicitis is a mechanical strangulation that culminates in tissue death. This physiological cascade dictates the narrow window clinicians have to intervene. The clinical presentation tracks this ischemic progression. It begins with poorly localized periumbilical colic, a referred pain reflecting the early visceral irritation of the distending organ. As the inflammation breaches the full thickness of the appendiceal wall, it irritates the overlying somatic parietal peritoneum. The pain shifts, becoming intense and highly localized in the right iliac fossa. Relying on this classic sequence is a diagnostic trap. The expected visceral somatic pain shift occurs in only about half of all patients. The remaining patients present with symptoms governed by their specific anatomical variation. A retrocecal appendix will irritate the posterior muscles, presenting as psoas spasm or loin pain. A pelvic appendix can irritate nearby structures, mimicking a urinary tract infection or presenting with diarrhea. To navigate this, clinicians use the Alvarado score to quantify clinical signs alongside targeted imaging. Ultrasound is the primary tool for children and women of childbearing age, while low-dose contrast CT scans provide the necessary diagnostic sensitivity for most adult patients. An accurate diagnosis relies on detecting the underlying anatomical position of the appendix from the patient's specific pattern of peritoneal irritation. Historically, acute presentation mandated immediate surgery. Today, management is driven by a stratified matrix of interventions. For uncomplicated cases, conservative management with intravenous antibiotics is now standard, achieving an initial success rate of approximately 85%. Up to 1/3 of these patients will require surgery for recurrent symptoms within a single year. Immediate surgery becomes dangerous if the patient presents with an appendix mass or abscess. Dissecting inflamed tissues carries high risk. Instead, clinicians employ the Ochsner-Sharon regime, relying on strict vitals monitoring, antibiotics, and radiological drainage. The conservative regime is abandoned if the patient meets strict failure criteria. A spiking pulse rate or an expanding mass dictates an early laparotomy. Modern appendiceal management is a highly calculated risk stratification. It is a constant balance between the threat of surgical morbidity in an inflamed field and the threat of progressive sepsis. When surgery is indicated, the patient requires specific preoperative preparation. This includes aggressive fluid resuscitation and intravenous antibiotics to reduce wound infections. The traditional open approach utilizes tailored incisions like the oblique gridiron. The surgeon accesses the cavity by splitting the external oblique aponeurosis along its fibers. Inside, the surgeon traces the Tenderness coli to safely mobilize the retrocecal appendix. Open appendicectomy requires precise anatomical navigation to safely separate and resect the inflamed tissue without rupturing the ischemic, pressurized walls. The laparoscopic approach has become the clinical standard. It reduces wound infections and provides crucial diagnostic visualization, especially in women of childbearing age, where gynecological pathologies can mimic appendicitis. Utilizing a Trendelenburg tilt pulls the bowel clear. The critical vascular step is skeletonizing the appendix. The surgeon coagulates the mesoappendix to prevent bleeding. Free of its blood supply, the appendiceal base is securely ligated utilizing a rotor loop. The physical reality of the pathology is stark. The clamped tissues are severely swollen, ischemic, and coated in purulent exudate resulting from bacterial invasion. The final amputation physically separates the necrotic tissue from the cecum, definitively removing the infectious threat from the patient's abdominal cavity. Regardless of whether an open or laparoscopic approach is utilized, the resected tissue must always be sent for histological review. The ultimate goal is to definitively rule out a hidden, far more dangerous pathology. The ultimate clinical trap in appendiceal surgery is the asymptomatic neoplasm. Most appendix tumors are discovered incidentally by the pathologist following a routine operation for suspected acute inflammation. Neuroendocrine tumors account for 30% of appendiceal neoplasms, typically located precisely at the tip of the organ. A tumor under 1 centimeter is generally cured by appendicectomy alone. However, tumors exceeding 2 centimeters or displaying high-grade features mandate a full right hemicolectomy. A second major oncological threat is the low-grade appendiceal mucinous neoplasm. These epithelial tumors pose a unique mechanical danger due to the slow, relentless accumulation of mucin within the appendiceal walls. The surgeon's responsibility does not end with closing the incision. Failing to follow up on the routine postoperative histology risks missing a silent, life-threatening malignancy inside the patient. If a mucinous neoplasm is allowed to expand until the appendix perforates, the result is catastrophic. The rupture spills viscous mucin and viable, tumor-producing epithelial cells directly into the open peritoneal cavity. This spill creates a condition known as pseudomyxoma peritonea, or PMP. It is a progressive, potentially fatal clinical syndrome defined by the massive accumulation of mucinous ascites and the formation of a rigid omental cake across the abdominal organs. The gold standard treatment requires 2 phases. The first is complete cytoreductive surgery, a massive operation to meticulously physically excise all macroscopic disease and affected peritoneal surfaces from the abdomen. The final phase targets microscopic disease. Using the HIPEC protocol, the surgical team pumps heated liquid chemotherapy directly through the sutured abdominal cavity, circulating the fluid to destroy any surviving tumor cells. The vermiform appendix is a formidable anatomical structure, capable of dictating everything from a basic ward admission to the extreme, highly orchestrated interventions of cytoreductive surgery and intraperitoneal chemotherapy.